Hi, my name is Rohan, and welcome to this educational video on therapeutic paracentesis. In this brief walkthrough, we will review indications, consent, and the procedural steps in successfully and confidently performing this bedside procedure. So let's begin. The main indication for therapeutic paracentesis is tense ascites. Tense ascites or grade 3 ascites is where the abdomen is grossly distended and very firm in palpation. Other indications include extra abdominal symptoms caused by ascites such as breathlessness. Less commonly, paracentesis can be required before certain imaging or abdominal procedures. Consent is ideally documented on paper, and the patient should be counseled on the following risks or complications: bleeding, pain, infection, damage to local structures, or even failure. In patients who exhibit evidence of umbilical hernia, it would be prudent to discuss the risk of hernial incarceration, as this is a rare complication in this subset of patients. Here, it is worthwhile mentioning bleeding risk parameters. It is common practice that platelet counts of more than 50 are deemed acceptable to allow for intervention. More controversial, however, is the role of INR. INR at best is a partial indicator of overall hemostasis, especially so in patients with liver cirrhosis who are thought to have a rebalanced hemostasis, as the liver affects both anti and procoagulant factor production. In summary, discuss with your consultant before proceeding if the INR is more than 1.5 and get their direction on what INR threshold they are happy with. You will start by identifying a safe location for insertion using ultrasound, assessing both iliac fossae. A safe zone is usually 2 centimeters both medial and superior from the ACIS. Remember not to wander too medially in order to avoid entanglement with the inferior epigastric arteries. Once identified, you can mark the insertion site with the back of a needle for reference. Now, you will thoroughly clean the ipsilateral hemiabdomen where you plan to insert the drain. Use 2 ChloraPrep sticks and allow for the chlorhexidine alcohol solution to dry before proceeding to the next step. Now to administer your local anesthetic. Good anesthetic efficacy will make the procedure easy for you and keep your patient at ease. You will have drawn up 10 ml of 1% or 2% lidocaine. You will start by injecting 3 to 4 ml superficially, creating a bleb using an orange needle. Then with a green needle, you will infiltrate your local anesthetic generously from the skin to the parietal peritoneum. You will stop, check, inject roughly every 2 to 3 millimeters, giving 1 to 2 ml each time till you reach the peritoneal space. After allowing some time for the local anesthetic to take effect, you will perform an ascitic tap. This has several functions. It increases the volume of ascitic fluid for analysis, gives an idea of how well your insertion site is anesthetized, and most importantly, it reconfirms the safety of your insertion site. In order to introduce your blunt-ended rocket drain, use your scalpel to prime the insertion site with a small, superficial 3 to 4 millimeter width incision. Initially, you will insert the drain by tipping it into the incision. Now, keeping the drain perpendicular to the abdomen, you will control the distal drain with your non-dominant hand, which will grasp the drain with the thumb and index finger. Your non-dominant hand should not move. With your dominant hand on the proximal part of the drain, you will twist, thrust, and drive the drain forwards through the layers of the abdomen. You will feel some give as you breach the parietal peritoneum and enter into the peritoneal space. You will confirm this by aspirating fluid through the drain by pulling back on the attached 20 ml syringe. Now it is time to discharge the catheter into the abdomen. To do this, you will bring both your hands to the blue connector point in the middle of the drain system. With your dominant hand, twist the proximal half of the blue connector anti-clockwise to unlock. This disengages the blue catheter from the metal guide needle. Then with your non-dominant hand on the distal half of the blue connector, steadily advance the blue catheter whilst keeping your dominant hand fixed. Once the white phalange is flush with the skin, remove the metal guide needle. Then replace the blue connector cap. Finally, secure the drain with 2 cannula dressings. Open the 3-way tap to allow for drainage, and thank your patient. Before concluding, there are some important post-procedural considerations we should discuss. Drain removal checkpoints are important to define. Time checkpoint. The drain should not be in for longer than 6 hours due to increased risk of infection. Volume checkpoint. This varies dependent on the size of the patient, their renal function, and liver function. Large volume paracentesis is defined as 5 litres or more drained. Overdrainage can increase the risk of post-paracentesis circulatory dysfunction. In patients at risk of this, consider a restricted volume checkpoint. Patient checkpoint. Once most of the ascites has been drained, the drain tubing can sometimes irritate bowel tissue or even the parietal peritoneum, causing localized drain insertion site pain. The drain should be removed if the patient experiences this. These are some of the general checkpoints for removal. Other important considerations include a clear handover to nursing staff looking after the patient with clear instructive procedural documentation. This improves patient safety in the post-procedural phase. Ensure human albumin solution is prescribed with a working cannula in situ. Give the patient instruction on maximizing drain output, e.g., massaging the abdomen towards the drain, regular rolling away and then to the drain. And finally, ensure you request and send the appropriate ascitic fluid analysis testing as listed. Thank you for watching this video. I hope it helps, and good luck with your next ascitic drain.